to start with. First, as always, we've done 794,133 PCR tests overall. And system-wide, we've tested 451,044 people, and the percent positive has been 16.48%. I mentioned the other day that that percentage has gone up just over the last month or so, in a fairly interesting point, really overcoming the cumulative numbers that we'd had in the past. And it gives the idea of how many people have been positive as a percentage of late. And then at Baptist Memphis, we've tested 69,291 people, and the positivity rate there is 10.44%. If you look at positivity percentages around the region, Arkansas 18.8%, Central Mississippi 17.7%. So these numbers have increased over time with the new wave of Delta. If we look at hospitalizations at Memphis, we have 93 people in acute care non-ICU beds with COVID-19, and we have 38 people in the ICU for a total of 131 cases overall. 28 of those 38 ICU patients are on ventilators. There's 79 people at Baptist DeSoto in non-ICU acute care beds, and there are 11 people in the ICU with COVID-19 for a total of 90, and 10 of those 11 people in the ICU at DeSoto are on ventilators. So we've seen this sort of stair-step increase in cases over time. So it would be 110 for a few days, then 120. Now it's up slightly over 130. So obviously not the direction we were hoping, but something that we have been seeing in other places and sort of expected. One other point to mention is that we have 80 ICUs, excluding a couple of specialty ICU like bone marrow transplant, neurology, that sort of thing. But there are 80 regular ICU beds, and there are 85 occupying ICU beds. Now that seems nonsensical at first, but all that means is that there are 5 people that are getting ICU care not in the usual ICU, and that simply means that that we're full at the time in the ICU. Those people are getting their care because we're kind of adapting to the situation and giving those resources in some cases to other places, but it's the sort of thing that you don't want to see as a trend. So far, we can utilize our ability to be flexible in a lot of services to accomplish this, but this sort of thing continuing in our city could land us in the sort of situation over time that people are seeing in Louisiana, Mississippi, where there's just no place to put people, and that's certainly not the trend that we want to see continue. And we're hoping to we're back to the old mantra of blunting the curve, a language that has gone away for a long time, but now we really are back to that sort of situation so that we'll be able to have beds and adequate care for people. So happy to answer any questions if there are any.
Hey, Dr. Threlkeld, it's Corinne. How are you?
Hey, Corinne, how are you? Fine, thanks.
I'm hanging in there. So 2 things I wanted to ask you about. The first is the Shelby County Health Department said today there is going to be another mask mandate coming for the county. Would love to get your thoughts on this. How much is it going to help blunt the curve, as you just said? And, was this a long time coming?
Yeah, and so, obviously always a lot of charge to these questions. The only issues I ever have had with a mask mandate was in the very beginning, in the first iteration of that way back. I did have some concerns about how they were going to be executed, how they were going to be enforced, because it was a time, you may recall, that equitable enforcement of the law was quite an issue at that time. And I think the police director at the time made a very good statement at that city council meeting where they talked about it and said, look, we're not going to go plucking people off the street for not having a mask. We're going to do it through businesses and the like. And that's continuing up to this point. You can see in New Orleans where restaurants are required to have either proof of test negativity within 72 hours or proof of vaccination. So these things are coming up in a lot of different ways. But I think that wearing the mask, and let's just think about the school example that I think will speak to it in the broader city. If you look at the studies in classroom teaching, first in Wisconsin, there were a couple of other states that participated in the CDC studies. There was surprisingly effective, surprisingly safe, surprisingly few transmissions of the virus in those studies. But the studies had 3 things that were kind of typical that I tell people. One is that they had adequate spacing. Number 2, they had universal mask utilization. Number 3, they had no Delta variant cruising around in the community. So we've kind of lost the ability to have that third factor. And I think the more aggressively we push the other two, the better we're going to be. This has always been a multimodal defense endeavor. So vaccination is the very number one thing that you can do, because it does in fact cut the rate of infections at all. Yes, there are breakthroughs. Yes, you don't get sick if you have that breakthrough. And yes, you can transmit it to others, but it's still on the order of an 8-fold decrease in the likelihood of you to get an infection at all, much higher than that at preventing more serious disease. But preventing those infections with the vaccine is the first kind of line of defense, I think, right now. Obviously, social distancing is very important. The old adage of if you're sitting next to someone in a room, then you may or may not have protection if they really have it, and you're sitting right next to them. If you're not in the room, you're not going to get it. And so social distancing remains important. And then masking, particularly in those situations where you can't be distanced from someone. If you're sitting at a table eating in a more crowded room, if you're in a meeting of sorts, if you're in a school classroom these days, then I think masking becomes much more important. Masking science has always been difficult to get a full handle on and to be precise on. That does not mean they don't work. In the very beginning, a lot of people who do what I do had doubts that they would be all that effective. Absolutely guilty. We thought, well, maybe it'll be is their nose. That's how a lot of common colds transmit more than through aerosols. Turned out that wasn't right. And so it turns out that when you have a situation like that school study that I mentioned, where both the person who already has the disease and somebody who doesn't have the disease both have masks on, it is quite effective at preventing the transmission. It is particularly important for the person with the disease to have the mask on, because a lot of those droplets that would be sneezed out or coughed out are going to be caught in that mask. And that's going to greatly decrease the amount of virus that's going to be sprayed out there. So I think everybody in infectious disease and critical care would favor everybody wearing a mask indoors. It is the CDC recommendation formerly. It went away for a while, and people have a hard time seemingly of going back and forth with that issue. But a friend mentioned the other day, it's like on the airline when they turn off the fasten seatbelt sign. That don't say we can't do that. You turned it off because you have to adapt to the situation. So I think it's good that they adapted to that. We hope it will be, not a long period with this Delta virus. That's a good and a bad thing. It's nice to have a short duration, but the reason it's short is that it goes through and hunts down people who are unvaccinated and some people who are vaccinated with lesser disease. So we hope it'll be a relatively short time for this to happen, and we can go back to the situation that we were in before this hit us. But we probably should have seen it coming a little bit more than we did. The Delta variant was at the doorstep and inflicting a lot of damage on other countries, even as we were sort of celebrating and taking off our masks. But I think that everybody, that takes care of sick people with COVID would agree that we have a problem with overload of the system. I mentioned ICUs everywhere are filling up. We have cities that don't have any resources left. Their ambulances are backing up in Louisiana and other places like that. That's when you really get into the positive feedback loop of danger. You don't have to die of COVID to die because of COVID. And if you don't have any place to go with your other serious illness, your stroke or other problem, people can die from COVID that way too. So what we have to do is we have to blunt the curve again. We have to get the total number of cases down, because if you get the total number of cases down, you will get the unvaccinated cases down. You will then get the hospitalizations down and the deaths and the utilization of all of the healthcare facilities down. And that's what we really need to aim to do. And if you wear masks, if everybody's wearing a mask indoors when they're at higher risk of transmission, that will cut the rate of transmission and the number of cases locally. It did it before, it does it in all the studies, and it'll do it again.
The second question I had for you pertains to vaccines. The FDA has now, I believe, authorized use of a third booster dose for people who are immune compromised. Can you talk about that a little bit? The efficacy of that? What questions should people be asking their doctors, and could they get those shots at Baptist?
Yeah, so you're asking specifically about the immunocompromised people, is that right?
Correct, not just the third dose for everyone that might be in the future.
On the doorstep, yeah, which is odd all by itself, because you had these rumors swirling around. It's just an unusual way for that to be communicated. But With respect to the immunosuppressed people, that's been obviously being thrown around for quite some time about the need for that, because 2.7% of our population right now in America consists of people who might not get adequate immunity from the vaccine. The classic case is solid organ transplant because it's so clearly defined as immunosuppressed. It's also happens to be the group where they did the first work with these studies of antibody production at Johns Hopkins and a couple other places. So that's the classic group. But the way the FDA came out with it was interestingly vague, sort of on purpose. The CDC came along then and cleared a bit of it up. They said somebody who's a solid organ transplant recipient, or someone with equivalent degrees of immunosuppression. That could be advanced AIDS, for example, not on therapy, somebody getting high-dose steroids for other sorts of illnesses, bone marrow transplant. So there are a number of groups, and that's the sort of thing that you need to check with your doctor to see whether you really qualify for that. So I think it's very reasonable. If you look at those studies, a lot of people in those situations, in those immunosuppressed groups, had no antibody response whatsoever. And then some had some antibodies, but not a lot. And if you took the third vaccine in the small trials, between the third and a half of the people that had no antibody before were able to generate at least some. And all of the people that had some antibody essentially increased that antibody. That's small numbers of patients that we're looking at. So it wasn't compelling, but there seemed to be little to no downside in doing that. And these people are at high risk. So it's very reasonable, I think, to try that third vaccine. And you can get it essentially anywhere now, including at Baptist. And so they really approved it for just the RNA vaccines. It would be presumptive that the Johnson & Johnson vaccine would probably be effective too, but they are waiting for the data. There are some trial data that are coming out shortly on the J&J to see how effective it is in that regard too. And the CDC and the FDA have taken some criticism for not, going ahead and approving that. But it's reasonable to wait for the data. It's like the childhood vaccines. We think they'll be effective. We think they'll be safe, but we would be very hypocritical if we didn't say, wait for the data. We need those data to really show about the safety and so forth. So I think it will be, helpful, but it's very important for people who are immunosuppressed to still be careful. You need to still avoid the infection altogether if you can do it. So you particularly should wear masks, and you should demand that people wear masks around you when possible, because it's the other person coughing the virus on you, an immunosuppressed patient, that is going to be the most dangerous proposition. And so in those situations, that's why, again, we see people all the time, and I'm sorry to bounce back and forth on the topic, but we see people say, hey, I'm vaccinated. I don't need to wear my mask in public. And the argument, to be stated fairly, goes something like this. People say, I'm vaccinated, I'm protected. There's little to no chance I'm going to be hospitalized or die of this infection. All true. They say I'm being asked only to protect those people who are unvaccinated. And those people had their chance. They didn't get the vaccine, and they're not even asking that I mask up. They're not masking, and they don't want me to either. So that's the way a lot of the argument goes. And I think there are two flaws in that argument. Number one is the topic you're asking about. There are that almost 3% of people out there who can't really get adequate immunity. For heaven's sake, we have St. Jude in our city. Those kids can't get immune by vaccination or otherwise, probably. And so people who are immunosuppressed need to be protected. And if you're not feeling, and those other people that might be at higher risk for other reasons, particularly those who haven't been vaccinated, the reality is that you're protecting them too, even though you're not at risk. And if altruism isn't enough of a concern for you, we have a self-serving option too. And that is simply this idea that if enough people get this infection right now and enough people therefore get hospitalized, you're going to tie up healthcare such that you will have nowhere to go when you get your automobile accident or other severe illness in about a month from now. So it will harm you too, again, with the idea that you don't have to die of COVID to die as a result of the fallout from COVID. So I think in that sense, it's just one more example of the way that we can try to protect those folks, and protecting them also protects everybody else as well.
Yeah, Threlkeld, it's Brad. How are you doing today, sir?
I'm good, Brad. How are you, sir?
Good. Just like Corinne, hanging in there. We all are these days. Kind of following up on Corinne's question. What do you think it says right now that Dr. Taylor feels the need to have to do this mask mandate with the trends that we're seeing, and what do you think it says of where Shelby County, the risk we're facing right now, and the hospital challenges, et cetera?
Yeah, no, it is. I think that's the reason. I think she appropriately and accurately gauges that risk. It is impressive. We are on a trajectory to reach those sorts of really serious, really depressing sorts of scenarios that people have seen in other places, namely Louisiana, some in Mississippi, and others. Can we escape it? Sure, we hope so, and we still can, but it's going to take our limiting the total number of cases. And the way you do that is obviously to be vaccinated, but also to do some of those behaviors that cuts down on the transmission, whether you're vaccinated or not. And then, even if you're vaccinated, you might be able to get a mild case and give it to someone else who then will get sick. And so you still have a role to play even if you're vaccinated. But I think the new director is very accurate, because right now we're headed toward the apex of this thing, and we hope that it will follow something of the trend of other countries and even a few states that have a very steep peak, a lot of infections, and then comes down a little faster maybe than some of the peaks that we've seen before. We saw that in India. We saw it to some degree in the UK. Now, there were cities burning in India because of it. That's not to say it wasn't a terribly tragic situation, but it didn't last as long as some of the previous peaks. But as I've said before, the hope that this will be short-lived is not a strategy to avoid disaster and unnecessary deaths. And so we have to have plans to, in fact, blunt that curve of cases. And so I think masks have been shown to do it. They've done it before. They do it in experimental evaluations, and they'll do it this time too. So I think it's reasonable. And people have to realize this is not a return to masks forever. In the same way that we took these off, we're just encountering a new problem with a new virus. And when Delta leaves us, we hope sooner than later, I think that the CDC and local health authorities will reevaluate that and go back to a bit freer situation. But again, I mean, just to go back to our experience on a daily basis, I just rounded on a dozen people in the ICU. They're all under 55. Some are not going to survive. We have people in the 20s, 30s, even teens in our ICU on the ventilator. This is a real tragedy. This is not made up. It's not. And yes, I will agree that you have a low chance individually of dying of COVID if you get it. Any one person has that. But our whole hospital is filling up with people who were very certain that it couldn't happen to them, including people who have died. Thought that. And so when you have the degree of transmission that you have in this virus, and this is, I think, again, back to what the new health department director is saying, when you have the degree of transmission that we're having, 20+% testing positive, we know that there is a lot of virus out there. And when that's the case, it's going to filter down into some hospitalizations and some deaths as well. So being able to turn off that cycle is what's going to do the trick for us to cut down on all of these other things that could spin out of control because of it. And so I think most of us, again, who are in healthcare seeing these people, are supportive of this sort of more aggressive posture right now. And the same thing is true of schools. I mean, I think we said before, I mean, my thought was that we should be fairly aggressive with masking and distancing and so forth during the first just 2-3 weeks of school even. Had we done that, we would have an idea of how safe the situation was, and we would have a baseline of transmission. It may be that the Delta variant is going to transmit well regardless of what we do in the way of behaviors. We won't know because we didn't really do that fully. And so now you're seeing, particularly in places that don't have mask mandates in school, their districts are practically shutting down. Everybody agrees that what we want is for schools to stay open and people not to die. And if we can just do those two things, we're well on our way to what we need to accomplish. But it turns out that the best way to keep schools open is probably to really work hard at decreasing virus transmission. Then if we get very little transmission, then we can relax that. We found that last year when this happened, we were pessimistic. Things were harder to transmit in the school situation at that age group than we had feared they were. But now we have a much more contagious virus, and it is doing perfectly fine, thank you very much, at transmitting among children and young adults. And so we see those things happening now, and anything we can do to limit this peak, which is likely to be a limited time, is going to pay a lot of dividend as we move forward. Any other questions? I have a few questions from the feed. I will just answer a couple of them. Carolyn Bastian says, my son was quarantined one time the beginning of August last year from, quote, being exposed, unquote, and that was it the entire year. No masks. How do you explain people in the same house not passing it to each other? It's a good question. And, before I tell people that, during with the Wuhan variant and the Alpha variant even, which was more contagious, that's why it replaced the Wuhan variant, but they were significantly less contagious than this variant. I point out to people now that it used to be you could slide the food under the door of somebody who was sick in the house, as we mentioned, and a lot of people might escape it. People in the household aren't escaping this variant. So it is, in fact, much more contagious. And I mentioned that in schools, transmission in schools was not nearly as widespread and severe as we had feared that it might be before. We thought it might just be a transmission chamber for the virus. We're getting a lot closer to that sort of fear this time. And again, look at nothing, if you like, other than the number of kids in quarantine in the Collierville system and some of the systems in Mississippi and Texas, where entire school districts have had to close down initially. If the hope is to keep our schools open, we probably need to be more aggressive as things are playing out right now. And how long? I mean, we'll have to see. But obviously, it's not working very well at stopping that transmission now, simply because it's a much more contagious variant. Kelly DeWitt asked, my daughter is 14 weeks pregnant with twins. She had the UK variant in March. When should she get vaccinated? Was told to wait until the second trimester, which is now. And so I won't belabor this point, but the pregnancy and fertility issues are probably the most problematic rumors and misinformation that is out there regarding the COVID-19 pandemic and the vaccination situation. The recommendation from the American College of Obstetrics and Gynecology, as well as the Society of Maternal and Fetal Medicine, is to get the vaccine now, no matter when now is. If you're thinking about getting pregnant, you're trying to get pregnant, your first trimester, your third trimester, the answer is to get it now, because there are no data that suggest that there is a downside in any way for that pregnancy. And the data of protection are impressive. We've seen many people get intubated on the ventilator who were pregnant. We've seen a death or two. And there's nothing worse for an unborn child than a mom who can't oxygenate. And so it is very clear that that is the best strategy to move forward. We can talk later about the fertility issue. That also is sort of a vicious rumor that seemed to take off really heavily, but there's zero truth to that whatsoever. And then finally, Dorothy Golden asked, I would like to talk about testing discrepancies. Family member tests positive at rapid test and negative at Poplar Healthcare. Both tests within an hour. Who can I speak to for clarification? Well, I would say there are a couple of things. Remembering that the PCR test is not perfect. No test is. It's 80-ish% sensitive. There's some variability in that. The rapid test is even less so. It's 70-ish%, but it depends on the moment. One swab may have been better than the other, for example. There are a lot of variables that go into whether a test is positive. What is obvious, though, is that a positive test is much more important than a negative test, because they missed so many of them by characteristics of the test. You have to go back and then realize that it almost never gives a false positive. There's nothing 100% in that regard, but the false positives are almost unheard of. And so if you get a positive test, that greatly outweighs any negative test, even if you did two swabs at the same time of the different type. And the analogy that I have given for that historically is that if you go and buy a wildlife camera and take some pictures in your backyard at night, and you see a deer on the 5th frame out of 20, and the other 19 are all negative, there are deer in your yard. It doesn't matter what the other 19 showed. A positive test is just a lot more important and convincing than a negative test. And the same thing applies with these COVID-19 tests as well. So a positive test is important. I'm going to make one other point just again that I've made before, but it keeps coming up, and I want to make sure that people hear about this. I'm seeing a lot of people who are in the community, because there are just so many cases right now, and they are getting azithromycin and steroid, like a prednisone pack or Medrol dose pack, for their COVID case, or it's called in from an office, and they're fine. Their oxygen is okay, and they're getting those two drugs. I would caution you to ask your healthcare provider, if they give you that, exactly the reason to do it. Azithromycin has no activity against COVID-19. It's an antibacterial, not a viral. So you're really just opening yourself up to diarrhea and other sorts of side effects for really no particular benefit. Much more important, maybe, is the steroids. Steroids, in some of the trials that have been done, they are life-saving once you require oxygen and your lungs are being damaged like that in COVID-19. If you take them before you require oxygen, there was a trend toward actual harm in taking those in a good trial that showed this. And so steroids should not be taken if you are okay and not yet requiring oxygen and at home, not in the hospital. So that's an important thing that, very frankly, some people are getting those steroids at larger numbers than most of us are comfortable with. When we see them, a lot of people come into the hospital, they've been given steroid, and that is a problem because it actually can give the virus the upper hand. You never want to sort of take a steroid as long as it's the virus attacking you, the stage we're in. Once it gets to where the immune system is mistakenly attacking the lungs, that's when we turn around and take another tack by suppressing that immune system from damaging our cells by mistake. So those two things, just remember, if you are an outpatient and even if you're relatively healthy and you have COVID, remember those two things in your therapy. Stay hydrated, don't get dehydrated at home. Most of the people who come into the hospital seem to me to have kind of gotten either from the diarrhea or just insensible losses, breathing heavily and coughing. You can lose some fluid that way. Make sure you stay hydrated and do not take to bed to increase your chance of blood clots if you're just lying down all day, and you also kind of lose strength that way. So those things, I think, are the things that we know are helpful in fighting COVID as an outpatient, which so many people are right now. Any other questions? Okay, thanks guys. Have a good weekend.